what's important is that you now have a large phase 3 trial. The prior data was phase 2b, which had very strong findings. As we know in this field, succeeding in phase 3 is harder than phase 2. In part, the studies are bigger, more countries, more sites. And so there are several illustrations of drugs in recent development where phase 2 looked very promising and phase 3 didn't deliver. In this case, phase 3 really did deliver. The 50 milligram dose of Brilaroxazine had a very strong treatment effect on the PANSS, the positive negative symptom scale score, which is the gold standard for approval of a drug. And it was about 10 points above placebo response. And in psychiatry, placebo is almost a real drug. It affects behavior, whether it's expectation bias. There's a number of reasons for why trials have such large placebo response rates. In this case, the placebo response rate is modest, and there's a 10-point additional increment in improvement. So that's the most important finding. But then this study also supported improvements in negative symptoms and social functioning, which means you're treating more of the illness, because the illness is not just psychosis, hallucinations, delusions, thought disorder. It's difficulty doing the daily tasks of living. And so, again, this is promising and reinforcing that there is a signal here for social function as well as a reduction in negative symptoms. So at the broadest level, I think that's the efficacy signal. This is a complex drug, as I think you're alluding to. It's affecting multiple dopamine receptors, multiple serotonin receptors. And so this drug is different than, let's say, a risperidone, which is a dopamine serotonin drug. It's even has more receptor activity than aripiprazole. So its core is dopamine 2, serotonin 2, effects. But in addition to that, the drug has high potency, high affinity for a variety of serotonin receptors associated with a lot of other potential effects. For instance, D3 and D4, other dopamine receptors, affect frontal cortex signaling, which is important for thinking, negative symptoms. Serotonin 1A is an anti-anxiety effect from a drug. Okay, serotonin 2A we know is the antipsychotic effect, but then what is among the most potent effects of this drug is serotonin 2B. And this is where there's a very unique story, I think. It's emerging, and I've been involved in this field a long time, and I'm an advocate for, ways to treat the brain other than receptor blockade. And the area of neuroinflammation and damage done by inflammatory stress processes is really gaining support for Parkinson's, depression, Alzheimer's. And serotonin 2B seems to modulate the anti-inflammatory processes in the brain. So this is another gear, possibly, for this drug. Now, it needs confirmation. The next phase 3 trial will further study biomarkers, but there is some evidence that this drug is doing something that at least has not been demonstrated for other antipsychotics. I know that's long, but it's a complicated mechanism that's at work here, and I think there's convergence. Yeah, so right now, the phase 2 study, where you had a lower dose being effective against placebo as well as a higher dose, was done in countries where the patients selected were less ill, the PANSS scores were lower than in the phase 3, and importantly, and this has been seen with a lot of antipsychotics, about 245 or so of the patients in phase 3 are from the US. And the US, the patients were more ill and they weigh more. So what you end up with is, as has been seen with other drugs, the need for probably doses biased higher. So that's why I think the 50 milligram dose is so clearly, superior to placebo, and the 15 milligrams is more numerically better than placebo and only at the end point. So you'll see in the next phase 3, they'll be exploring an intermediate dose of 30, I believe. And so to me, I think that's going to be important for the approval, especially for the FDA, that they see the 50 and there's another dose. I've been involved with the FDA. They like to know the minimum effective dose. So, it's likely 15 works in stable patients quite well, less ill patients. It could well be a maintenance dose that's being shown to be effective right now. But for acute psychosis, where you're trying to control someone who's a danger to themselves or others, you need a drug with a higher dose. That's been shown elsewhere. So the 50 is rock solid. Both studies, phase 2B, phase 3, showed roughly comparable strong treatment effects. In fact, one way to look at these drugs is effect size, and the effect sizes are really quite notable. I mean, we're talking 0.6 or so for acute psychosis, if I recall correctly. So there's definitely a signal here that is very important. And so from my sense, the consistency is probably the most important. The phase 2, phase 3, 10-point improvement in PANSS over placebo, positive scale, about the same improvement, negative scores, all relatively similar. So that's a nice confirmation. But I do think it does raise the question about the minimum dose for the acutely ill subject. So there are a number of drugs in development as adjunctive therapies to add on to the current atypical antipsychotics for negative symptoms, for cognitive impairment, for social impairment. And what you're looking at here is, again, I mentioned part of the pharmacology of this drug. It's complex. We used to, in the very old days, I'm dating myself, but back in the chlorpromazine era, we talked about dirty drugs with a lot of pharmacology compared to haloperidol, pure D2. We've learned from this that's not actually right. Clozapine, the first atypical, is a shotgun of pharmacology. And so now that's called rich pharmacology instead of dirty, meaning overly complex. This drug has complex, rich pharmacology, as I mentioned. And I think that's why we're seeing changes that actually are reflected beyond the positive symptoms for the acute exacerbation. And that's noteworthy. These are 4-week trials, and we're moving the needle on some of the other more difficult to treat symptoms. Now, longer-term studies are going to be needed to really prove the impact on function and social capacity, so there's much to be done still. But these are very promising results, saying you're treating a broader spectrum of the illness. And so this drug may well do what otherwise could require combination therapy in the future with other drugs being developed for the atypicals on the market. So I sort of mentioned that a little bit up front because I think it is truly exciting. So the phase 3 trial, really one of the first large scale trials, reported out that there was improvements in BDNF, brain-derived neurotrophic factor. So this is in patients with schizophrenia on treatment. And, the BDNF improvement then results in decreases in the pro-inflammatory cytokines. All of us have seen on TV treatments for psoriasis, and these drugs block these interleukins, IL, this or that. So here you actually have a drug for schizophrenia that's affecting the inflammatory cytokine system, if you will, and that has tremendous implications. Have they been proven yet? No, we need more studies. But if this holds up, and the preclinical data is very strong as well, then these drugs may affect the brain damage that occurs in schizophrenia, especially in early treatment. Every single psychotic episode, exacerbation in the illness from baseline, actually damages the brain. It shrinks your brain tissue, literally. This may affect that, and I emphasize may, but it is a strategy that makes tremendous sense. Does it contribute to psychosis or other mechanisms? We really don't know, frankly. But long-term, changing the inflammatory system, into against the pro-inflammatory disease process could be a game changer. It's a little bit tangential, but it illustrates how different this drug seems to be from others. They're looking at taking this drug into, for instance, psoriasis. So we're talking an inflammatory skin disease. And again, the animal models in mice show improvements in, the combination of Brilaroxazine with a drug that causes chemical psoriasis. They're looking at it in pulmonary disease, hypertension, fibrotic illness. These have nothing to do with schizophrenia. And yet this drug seems to have a signal here. So that's a story still unfolding, but it is something that could differentiate. Sexual dysfunction has been a challenge for a lot of drugs. Many of our antidepressants have suppressed sexual function. The antipsychotics have impaired sexual function. And when you're talking about quality of life, staying on medications, well, this is a side effect where people will vote to stop meds to have a better sex life. That's just the reality of things. So if you have a way to reduce sexual dysfunction, that's amazing. And it needs further study. I do have to say that why only women and not men is a question that needs further study. But the evaluations that were done are fairly striking. They used a sexual function questionnaire. It's called CSFQ. And on the women, both 15 and 50 showed, an improvement in sexual function. So the scale scores, you go up higher, you're moving towards normal sexual function. Dramatic in women, but not in men. Again, we're talking 4-week trials. And sexual dysfunction is a long-term challenge. So it's possible that men will follow with a longer dose. It's, questions about that. But for women, this is a very important finding. It really could affect adherence, quality of life. And we know some of the reasons for that. Prolactin, which is the hormone that helps women secrete milk, it stimulates the breast, suppresses sexual function and other hormones. So it's not surprising that a drug that doesn't increase prolactin might even lower it somewhat from baseline because of that partial agonist effect. May be part of the story. It may be linked to other hormonal changes, thyroid. But again, how much is it this combination of negative symptoms, social, and some anti-inflammatory effect, converging to do something that's pretty novel? So again, with all these nuances and differences, the next phase 3 trial is replication. That's important. And the long-term extension studies are demonstrating, but need to go out the full year plus to show there's a sustained effect. And that effect isn't just treating psychosis, bringing psychosis down, because these are all acute exacerbation studies. And so there's a little bit of a combination of calming psychosis and what else improves because of that. What we can say is it appears there's a bigger improvement here than many other drugs have shown, but it's not head to head. And, in my opinion, again, it's the long-term treatment that will demonstrate these are real. The fascinating part is that they're not notable. So again, in the phase 3, the discontinuation rate for 50 milligrams, the research subjects vote with their feet. If something bad is happening to them, they will tell the investigator, take me out of the trial. I'm not feeling well. So the all-cause discontinuation rate was 16%, which is, remarkable in the phase 3 trial. The placebo discontinuation rate's 22%. The rate of discontinuation due to treatment emergent adverse effects, we call it, in other words, something occurring that causes dropout, was 0 in the phase 3 trial. And I believe in the phase 2, there was like one subject, 1 point something percent. That's remarkable. Yes, there's a lot of reports of things like, some sedation, there are certainly effects seen, but placebo causes side effects too. So there definitely is a excellent tolerability. Are there side effects? Yes, some people get sedation. A tiny minority of subjects may get a little restless, depending on their sensitivity to the drug. And again, that's why you need multiple doses for this drug. I'm not a believer that one dose fits everybody. It's just counter to pharmacology, frankly. There's several areas that are being looked at. Certainly, acute schizophrenia, the phase 3 replicated trial, is very, very important. I believe that this drug and the pharmacology that we talked about really supports, when all is said and done, the drug likely to be useful in bipolar disorder. And, bipolar mania, most drugs that are effective on schizophrenia likely work on mania. But I think that the pharmacology of this drug, it has some pieces similar to aripiprazole, brexpiprazole, and brexpiprazole is a major treatment for people who have partially responding depression. So it's added on to standard therapy with dramatic improvement. I think this drug will have antidepressant effects, is the point I'm getting at. And I think we're going to see work done in that area. There's some discussion, I think, in forward progress to look at attention deficit hyperactivity disorder, which is something you just don't expect a antipsychotic to be used for. We use drugs like stimulants, methylphenidate and others. And so will this drug work there? That requires clinical testing, but I believe that's going to be evaluated. And that could be because, again, of this complex pharmacology. There's, the sum of the parts does more than you might think. And so to be continued. I think the area that is fascinating is, again, the anti-inflammatory. I've already sort of made that clear that this is part of the future of treating people with brain disease. And I'm hoping we will see, replication in humans of what's been seen in the animals for both pulmonary diseases, fibrosis, arterial hypertension, and even more prevalent, psoriasis. That could be fascinating if this drug works for psoriasis. So, that would just say mechanistically something is quite different here. So that to me is the area. The other, which is a a side effect that is worth mentioning, and it needs further study, is the relative absence of weight gain, but there was a weak signal in phase 3, compared to phase 2. My sense is, welcome to the United States. Our way of treating patients, the amount of food we feed in a hospital, in a research setting, is way above the calorie content most people eat in this world. So, there needs to be a look at the long-term trial is where I'm getting at again. The 4 weeks, you're improving psychosis, you're changing the person's ability to interact with their environment. Food is comforting. So what's the drug look like longer term? And again, the data is still preliminary, but it looks like the drug could well be weight neutral over the course of a year. And again, that's another future research area that I think will answer important questions about this drug. The phase 3 study was well conducted. I've been involved with a lot of drug development. I go back to being one of the principal investigators for clozapine, for the early long-acting injectable drugs on forward. And, to me, the strong signal against placebo and the consistency between phase 2 and phase 3 so far for that 50 milligram dose group is important. So I'm looking forward to the second phase 3, which is in sort of the gear up phase right now. And, I hope the results will replicate the previous study. But as we know in clinical research, it's not a foregone conclusion. Even with a drug that's fully effective, clinical trials are a challenge. And the other comment I'll make is that my sense in talking with the study team, with implementation of the study, Reviva is hands-on. And that to me is a key to success. They're involved in looking at the sites, in monitoring the sites. A lot of companies sort of delegate to what we call CRO, to monitor the sites and so on. I think being more involved and partnering with the CRO that's going to run the study is an important key to success. So let's, be optimistic, but, as I said, you can't bet 100% on anything in psychiatry working. But this, I think, is a solid drug, and it's going to be an important addition to the armamentarium. So I'm hoping to see this drug get to patients in the real world soon.